Good morning, everyone. I would like to thank the sages for this nice opportunity for me to present here on this podium, and thanks for the moderators. I'm going to talk today about whether sleeve shape can make a difference in outcomes. Here are our disclosures that are not pertinent to this talk. As many of our colleagues today mentioned, that sleeve gastrectomy is becoming the most common performed procedure, a bariatric procedure, not only in the United States, but also worldwide. And for that, many studies suggested that sleeve shape may affect the outcomes of sleeve gastrectomy. So we wanted to look whether calibration devices from endoscopic guidance to a large bore or a gastric tube or the fenestrated suction tube can make a difference in the sleeve shape. So we had two questions to answer in this study. The first question, which calibration device creates the most consistent sleeve shape? And then, does the sleeve shape really affect the outcomes in terms of reflux and weight loss? To answer that, before we go into the methodology and results, we chose our definitions like strictly in a way to get the robust data possible. So the successful weight loss was defined as more than 50% excess weight loss at 1 year. And we defined Denovo reflux as no use of proton pump inhibitors preoperatively, but patient continued on using it for the first year follow-up. We included 210 patients who underwent sleeve gastrectomy as a primary procedure, and all of these patients underwent also esophagogram the first postoperative day. The period was from 2011 until 2015. We included different demographic data and clinical outcomes. We used the 3 different calibration devices over these 4 years, from endoscopic guidance, large bore orogastric tube, and fenestrated excision device with suction. All of our esophagograms were reviewed by 2 radiologists who were blinded to the outcome and were instructed to follow a previously described sleeve morphology. So here we can see in this picture, we had the dumbbell shape where we can see a retained proximal part of the stomach and retained antrum. And then we have the lower pouch where we can see retained antrum, and the rest of the stomach is tubular. And then in the tubular shape, all of the stomach is tubular. While in the last picture, we can see the upper pouch, the dilated proximal stomach. We used the one-way ANOVA and t-test for clinical differences, and for comparisons, we used Fisher's exact test and logistic regressions. Our results came, majority of our patients were females, 82%, and then the mean age was around 46 years, and mean BMI 47. The patients have multiple comorbidities, but we noted the higher percentage of patients had obstructive sleep apnea. And in regards to our sleeve morphology, we noted that around 39% of our patients came in the lower pouch group, while the least group came in the upper pouch with 7% only, and then 21% for dumbbell and 33% for tubular shape. When we looked at the association between the uniformity of the sleeve shape and calibration devices, so first of all, we noted that any sleeve, used tube can yield to any shape. But in the endoscopic guidance group, we noted that 47% of patients were in the tubular shape, while we got the lower pouch shape when we used the large bore orogastric tube and the fenestrated suction tube. At 12 months follow-up, the mean excess weight loss was around 60%. The majority of these patients who made it successfully at 1 year and lost more than 50% fell in the lower pouch category. When we looked at the Denovo reflux and its association with sleeve shape, we found that the higher incidence of de novo reflux happened in the tubular group with 53%, while the lower pouch had almost 36% of reflux. Looking at the literature, we found two studies that looked at the sleeve shapes. The majority of their cases fell in the tubular shape, but in our case, it was the lower pouch. In a study conducted by Toro et al., the higher severity of reflux was in the upper pouch group versus other groups, while the least reflux symptoms were in the lower pouch group. And while Lazora et al. Found a higher incidence of early vomiting and regurgitation in the tubular shape. So, and that goes with our study because we found a trend that was less de novo reflux in the lower pouch group and more de novo reflux in the tubular and upper pouch groups. Maybe the difference, our results were not statistically significant because of the strict definitions we used and the maybe smaller patient sample. In one of the Mebasquib recent published data in 2016, Berger et al. Said that the greater the distance from pylorus, the greater the weight loss. So when we are going further from the pylorus, we are achieving more retained antrum, and that also goes with our study because most of our patients were more than 5 centimeters away from the pylorus. So we found that the lower pouch has most weight loss. In conclusion, we found no association between calibration device and the final sleeve shape, so maybe the surgical technique or the surgeons himself are important factors in that part. But the most desirable shape for us was the lower pouch shape that leads to more weight loss and less reflux. So the surgeon should use his preferred technique to get the best outcome. Thank you so much.
The floor is open for a question. I have a question for you.
Yes.
Do you have any objective measures for reflux after this procedure when you compare those three types? Do you do a pH studies post-op or other studies that look for GERD? So
this is a great question. Thank you. Usually in the first 3 months post-operatively, we are giving all the patients PPI. And after that, when the patient comes like before 1 year, we may think, or before 6 months, we may think that there is non-compliance maybe with the PPI use. But after that, of course, when the symptoms are persistent, we do our studies, pH manual, for example, the Bravo technique, and we do, of course, endoscopy, and we see the esophagitis.
How many surgeons were involved in this study, and how did you decide? Was it personal preference of each surgeon, or were you randomized? How did that play out?
Okay, so this is a great question also. So there were 2 surgeons in single institution, and the difference actually in the calibrating devices came from the, evolved throughout the practice, because initially they were using endoscopic guidance, then orogastric tube, the large bore one, and then later on the fenestrated section.
So it was really like 3 cohorts over 3 time periods as you evolved with your choice of bougie.
Yeah.
Got it.
So there's a question back.
Okay. Peter Gorecki, New York. I was wondering whether you gave any thought to see the emptying of those pouches, because the static pictures are very difficult to really judge. It all depends on degree of intraluminal pressure that you can achieve with that extra swallow that can really show that retained fundus. So because sometimes they look beautiful, and then you give them another 3 sips, and things kind of building up. So that kind of single static picture may not be the most representative. So did you give any dynamic of gastric emptying thought?
This is a great observation, actually. It was one of the limitations in our study that we were looking at this the static picture because we couldn't download all of the dynamic files. So you were right. Yeah.
Thank you.
Okay.
Thank you.